Gangairan sir, Padma sir, our colleagues, friends. So we will be having our breakfast with me today by the Head and Neck Surgical Oncology Department. So we have three speakers, Dr Anjana Saseendran, Dr Abhijit George and Dr Shawn T Joseph. Unfortunately, I think Abhijit is sick, so he won't be presenting today. We will try to incorporate him later in some other CMEs. And the session will be chaired by our own VP Gangairan sir and Dr Vivek Matthew. So we request the chairpersons and speakers to please come on stage and start the proceedings. Thank you.
While the chairpersons get on stage, let's wish each other a very happy 2023.
Good morning to you all. I think we'll straight away go to the business. I think today's two topics only. I think they said they will spread out to cover up the time which has been given for Dr. Abhijit. First of all, Dr. Anjana is going to talk on the differentiated thyroid cancers and with our own data and analysis. Dr. Vivek, anything?
No, I think I am familiar with this data. I've seen this many times. Probably I think Anjana, you can directly go straight and we'll have a discussion or a conclusion towards the end. The management of differentiated thyroid cancers have gone a paradigm shift in the last 5 to 10 years, and our own data will probably reflect that.
Good morning everyone. So I'll start with my presentation. So let me start off with a case scenario. So this is a lady, 34-year-old lady. She had complaints of swelling in the neck. So she went for an evaluation at an outside hospital and was diagnosed to have papillary carcinoma thyroid. So she went and underwent thyroidectomy from the same center. Histopathology came as conventional papillary carcinoma thyroid with no aggressive features. So she was placed under low risk category, and post surgery she underwent radioiodine scan and ablation. After 3 months, her UPT became positive. So what next? She was advised to terminate the pregnancy. So again after that, she had persistence of disease in the thyroid bed. She was advised to do radioiodine ablation again. So then she came to us with these complaints. So what could have been avoided? So answer to this will be there in my presentation. So we'll discuss this after the presentation. So papillary carcinoma thyroid is the most common thyroid cancer, and it accounts for 70 to 80% of cases of well differentiated thyroid cancers, followed by follicular carcinoma. So the incidence of papillary carcinoma is rising tremendously since 1980s in the developed countries, and in particular in Kerala, this incidence is rising tremendously. There has been an increase of 3 times in the last 30 years. And this is the second most common cancer among females in Kerala. And we have already operated 17 staff from Lakeshore for malignancy, and that's such a huge number for a small population. Now most of them are asymptomatic, and most of the nodules are incidentally detected in the ultrasound done for some other purpose. So if the nodules are very common. So if you take 100 people, 70 of them will have nodules, but only 5 of them will be malignant. So ultrasound is the most important diagnostic tool in detecting the thyroid nodules, and it is not CT or MRI. So according to ATA guidelines, we follow ATA guidelines, 2015 is the latest one. So in the ultrasound, we specifically look for suspicious features. So it's given highly suspicious, intermediately suspicious, low suspicion. So some of the features that we look into is microcalcification, irregular margins, taller than wider nodules, hypoechoic nodules specifically. It is also important to look at the nodal status. That is really important. So mostly the level 6 nodes and also the lateral compartment nodes. That is level 2, 3 and 4. So according to ATA, some of the significant features are microcalcification, cystic aspect, hyperechogenicity, etc. So when should we evaluate the nodules? Do we have to do FNAC for all nodules? No. So according to the guidelines, if the nodule is less than 1 centimeter, you don't have to do an FNAC, even if there are suspicious features actually. But if there are if the nodule is more than 1 centimeter and if it is highly suspicious or intermediately suspicious, then you have to do an FNAC. And for those with low suspicion and very low suspicion pattern, FNA has to be done only if the nodule is more than 1.5 or more than 2 centimeters in size. So rest of the nodules actually you can observe by serial ultrasound follow. So FNAC, the Bethesda system, that's the reporting system for the FNAC. According to that, Bethesda 4, 5 and 6 are the follicular neoplasm, suspicious for malignancy and definitely malignancy. So this third column, it shows according to US multi-institutional, this is a US multi-institutional data. So according to that, they looked at the accuracy of the data, accuracy of the Bethesda system, and they found that around 25% of those reported as follicular neoplasm becomes malignancy, and around 70% and around 99% of Bethesda 5 and 6 turn out to be malignancy. So we compared our data and we found that around 100% of Bethesda 5 and 6 that are reported here turns out to be malignant, and around 71.4% of those reported as 4 turns out to be malignant. Now, surgery is the primary modality of treatment, and radioiodine scan and ablation is usually reserved for selected cases. Selected cases as an adjunct. So by management, our main aim is for a complete surgical ablation. So during surgery, we generally look for we also look for central compartment clearance. So by complete surgical ablation, we look for the nodal status, the level 6 and level 2, 3, 4. So for those cases reported as Bethesda 4, 5 and 6, we generally look at the central compartment, at least the inspection is done, and most of them will undergo prophylactic neck dissection. And those in the level 2, 3 and 4, according to the ultrasound report, we send the node for sampling. And we found that around 15% of the nodes turn positive and they are not suspicious in the ultrasound. And also for complete surgical ablation, we do thyroglossal tract excision, and in case of an extrathyroidal extension, we also try to take out margins. So if there is a gross extension into the strap muscles, we take sternothyroid muscle, a bit of sternothyroid muscle also. And we also try to remove the pretracheal fascia. So we also keep in mind this particular paper, that is a long-term side effect of radioiodine. There are incidents of second primary among those patients who take radioiodine. So we try to selectively use radioiodine among patients. So by all this, we try to de-escalate the treatment. So we try to do avoid unnecessary surgery, that is FNAC is only required. Reduce the number of surgeries as well as redo surgeries by picking up nodes in the first surgery itself, so that they don't have to undergo a neck dissection in a later date. And also we try to cut short post of adjuvant treatment by doing a meticulous surgery. So coming to the data, approximately 11,000 people presented to a OP with complaints of thyroid nodule, thyroid related complaints, but only 738 patients underwent surgery. Out of that, only 458 had malignancy. So we did a retrospective analysis of that 435 patients which are well differentiated thyroid cancers and which were operated in the last 8 years at our department. So we divided them into two groups. Group 1 consisted of mainly patients who were primarily operated in our department. So I'll be talking mainly about these patients. And group 2 consists of those patients who underwent revision surgery or for persistent disease. Their primary surgery was done elsewhere. So in the first group, 69% of them were females. And unlike other cancers, most of the patients are young. And we don't do subtotal or neototal thyroidectomies anymore. And as I said earlier, we started doing more of prophylactic central neck dissections as well as node sampling. And we that was something that we incorporated in the last few years after analyzing our data. And so as I said earlier, 15% of the patients were detected to have malignant cervical nodes on frozen section, and these were not suspicious on ultrasound neck. So once the histopathology report comes, we divide the patients into, we stratify the patients into 3 categories. So there are low risk, intermediate risk and high risk. So low risks are those patients who have intrathyroidal differentiated thyroid cancers and less than 5 lymph node micrometastasis. So if the histology is aggressive like Hobbs pattern or if there is a dorsal variant, then the patient goes into the intermediate category. And also if there are more than 5 lymph nodes, it is considered in the intermediate risk. And if there is gross extrathyroidal extension or if there is distant metastasis, if there is incomplete resection, all these patients goes into high risk category. So low risk in our, according to AJ guidelines as well as how we follow is, for low risk, we follow them serially with thyroglobulin, antithyroglobulin, TSH as well as ultrasound neck every 3 to 6 months. For intermediate and high risk, we generally advise the patient radioiodine scan. Based on the radioiodine scan and thyroglobulin reports, we advise radioiodine, whether radioiodine ablation is required or not, we'll decide. So according to our series, around 45% of patients were in the low risk group. And around 219 patients underwent radioiodine scan. And 45% of the patients had nil or minimal uptake in the post-operative scan. And or of those who underwent the scan, 59% underwent therapy as well. So while following, these patients need lifelong follow. So while following up these patients, we follow something called dynamic risk stratification. So according to this, there are 4 groups: excellent response, indeterminate response, biochemically incomplete response, and structurally incomplete response. So this is basically we are looking at the patient's response for following surgery. So if putting it in simple terms, in excellent response and indeterminate response, we are generally looking at the thyroglobulin levels as well as the radioiodine or the ultrasound scan report. So in ER and IR, thyroglobulin level is low, it is either less than 0.2 or less than 1, and scan is negative. That means there is no disease. And in biochemically incomplete response, there is increase in the thyroglobulin level, but the scan is negative. So 10 is like thyroglobulin elevated, negative imaging scan, all those things comes in the VIR group. Structurally incomplete response means in the scan there is a disease. There is disease in the scan, and thyroglobulin level will be generally elevated in this group. So that means the disease is persisting in the neck. So this is how we generally divide the patients. So this data shows that on those patients who did not receive radioiodine ablation, around 96% of patients were in the ER and IR group. That means the thyroglobulin levels were low and scan was negative. And in those patients who received radioiodine ablation, around 76.7% were in the ER and IR group. Now this, I have put this table just to tell you that even if in the histopathology, the risk category, when we do the risk category, even if the patient belongs to the high risk group, say or the intermediate group, say for example, if patient has extrathyroidal extension, or if the patient has an aggressive histology, we put them in the high risk group. But with meticulous surgery, that is if there is an extrathyroidal extension and if we take out the whole thing along with a bit of strap, if we could take with margins, and with meticulous surgery, it is possible for the patients to come into the ER-IR group. So that is one good thing about the thyroid cancers. Coming to recurrence, in our data there were no local recurrence. However, 3 had regional recurrence, but after redo surgery, they remained free of disease. And 15 patients had distant metastasis. So when talking about recurrence, it's important to mention about this particular paper. It's an Italian paper. It had there were 8 institutions. So they found that whenever the relapse occurred in a papillary carcinoma thyroid, they well differentiated cancers, all relapses occurred within 8 years. So in the first 10 in their study, they found that 10 recurrences occurred in the first 5 years and 5 occurred within the first 3 years. And they also found that recurrences were unrelated to the use or omission of post-op RAI ablation. Coming to the second group. So these patients were treated outside, and then they had recurrences, or to be specific, they had persistence of disease. Because most of the patients, they came within 1 or 2 years after the surgery, and they had persistence of disease. Among those patients, we found that around 52% of the patients after revision surgery were placed in the ER and IR group. Now this is another paper. So in this paper, what they're saying is more than half of the patients in this study, there were more than half of the patients who were reoperated within the first 2 years. It was more of a persistent disease than that of a recurrent disease. So coming to the conclusion, papillary carcinoma is very common. It is common especially in young women, and most of them are indolent, and we don't have to evaluate all the nodules. We can follow the ATA guidelines, we can look at the suspicious features, and we can do FNAC whenever you feel it is required. And when surgery is indicated, it is better to get a expert sonologist to do an ultrasound, because as I said, you have to look at the nodal status also, and meticulous surgery is required. And so what we have incorporated in the last few years is intra-frozen section and prophylactic central compartment clearance, and because of that, redo surgery could be avoided, and even radioiodine scan ablation could be avoided. Then a significant number of patients may have metastatic cervical nodes and extrathyroidal extension, which are mostly detected on table. Thank you.
Thank you for the presentation. But you never went back to your previous case in your line of management.
About the case in okay. So I'll read the scenario again. So this was a 34-year-old lady. She had swelling in the neck. She was diagnosed with papillary carcinoma thyroid. And histopathology came as conventional papillary carcinoma with no aggressive features. By no aggressive features, I mean no extrathyroid extension. They have not done a neck dissection, so nodal status we don't know. But based on the thyroid histopathology report, was a low risk category. So according to low risk category, we could have serially followed up with thyroglobulin and ultrasound, provided they have done a meticulous surgery with nodal, like looking into the node status as well. So post surgery, she underwent radioiodine scan as well as ablation. So that means that could have been avoided. So that's my point.
That's fine.
The only two things, even though they say for the next 6 months you should avoid getting pregnant. Now, if you look into the thyroid gland formation, it actually forms at the from the 19 to 22 weeks. Now, if this lady really want to go out with pregnancy, right? I mean, she has to go out with pregnancy. Technically, you wouldn't be wrong to say maybe you could go out with pregnancy because because this gland hasn't formed. Your major worry is the fetal thyroid gland that is formed. But then conventionally we do say that for the first 6 months to avoid radioiodine. I'm just passing a comment. That's a thought nowadays that is there. The second thing is that, like you said, in our population also, there are many of such low-risk patients whom we have decided against radioiodine, and many of them have become pregnant in the next 6 months. So this is a good thought process as such, because you could avoid and they could plan for an early pregnancy. And there are some whom we wanted a closer follow-up, and we told them specifically maybe you can avoid pregnancy for 1 to 2 years, but then again they have become, unfortunately or fortunately, has become pregnant in the first 1 year, and we have followed them. Nothing has happened so far.
I think a lot of controversy is tried, but I think the time will not permit. Anyway, I think you said less than 1 centimeters on ultrasound. You will go for a serious follow-up if features are all favorable for you. What is the follow-up pattern?
So every 3 to 6 months we could do an ultrasound.
How long?
Can I take the question? See, less than 1 centimeter, if other very suspicious features like microcalcification are on, it becomes difficult to explain to the patient not to do an FNA. So we usually go for an FNA if the nodule can be biopsied. If features like microcalcification, irregular margins, indistinct borders, taller than white, but otherwise we usually don't do an FNA and we follow up the patient. And these patients, or even patients, they would undergo an ultrasound every 6 to 12 months. And if there is an increase in volume by 50% or increase in size by 20% in 2 dimensions, then the patient would go for an FNA. In case the FNA comes benign, again the follow-up pattern would be increase in volume by 50% or 20% in 2 dimensions. That's how we are following up.
So
that's the ATA.
So this is because there has been a few studies that has come from, I think, Japan, Korea, as well as US. So during the autopsy time, they did find that there's a lot of patients who had microcapillary carcinoma, and they had recorded to have nodules before. They are having these nodules. So they decided to follow up those patients with microcapillary carcinoma maybe for 10 years. And what's happened was that the total increase of around 3 millimeter or 10 years, that will kind of come to around 100% increase in volume. That was around 2 to 8%. Now a total increase of 50% in volume. I think that would be the best, earliest it could be detected by an ultrasound. So that would probably come to around 10 to 14% over the 10 years. Now, finding up a new lymph node in the central neck node, over the first 10 years, it was around 2 to 4%. So what's really important was that their disease-specific mortality or morbidity did not change, even if you decided to observe these patients and maybe operate at the end of 10 years. So that's probably the reason why the ATA now recommends that those people with a micropapillary carcinoma, proven or unproven, like a high-risk features that you have, you could avoid an FNA. and maybe you could just observe maybe for 5 to 10 years in selected group of patients. But unfortunately, I'm still not able to convince a patient who have very high risk features and you tell them this could be cancer, but we'll just follow up. That's not possible. It is very difficult to do that. On the other hand, there are patients with adenomas, parathyroid adenomas, who are asymptomatic. And you have found a parathyroid adenoma, but there are no hardcore indications of surgery. So I have 5 or 6 patients with a proven parathyroid adenoma. You are just following them up without doing anything. So the moment the name cancer comes, it becomes really difficult to.
Before giving the mic to HR, what is the problem with the FNSC? If you're going for an FNSC at that point of time, or do you anticipate that I will not do an FNSC, but I'll go for a very close serial follow? Because I think status is the one which guides you purely. But what is the problem of going for an FNSC if there is suspicious nodule? You got
Why you should go? You ask him
why you are not going? Because I think, what do you anticipate as a complication by going for an FNSC?
Yes, it's finally a clinical decision. A lot of individual factors should be considered. But it's just that the number of thyroid cancers are increasing in such a big number. Many of them are indolent. If we do an FNA, it may come in this category 3, 4, 5.
Fully agree. What I'm telling you is, see, this is the problem which happens with not only with thyroid cancer, most of the malignancies, like where you say that you closely follow the occupancy. I think that's what I want to give a comment, I think.
No, I wanted to ask about the phenomenon of having a very under pressure radiologist, where you have you send the patient with a small nodule and they are afraid to say this is completely innocuous. So they have enough criteria for you to do FNAC. And once the FNAC goes to the pathologist is also quite afraid, and therefore they give you enough information so that Shawn can then go and take the thyroid out. So I want Anjana to tell us how often that happens, that the final biopsy is negative. I guess it's bound to happen now and then, but what is the percentage? And the second question is, you need to emphasize, you talk about meticulous surgery. I think in the old days people were afraid to do a total thyroidectomy because of the fear of nerve injury. And perhaps you can say a couple of words about how that is avoided in the current scenario, because I think the general population feels the more radical you are, the more damage you create. So when you do a central compartment lymphadenectomy, and then if the histology is going to be negative finally, that's a little bit of an overkill. So how often does that occur?
I think for the first question, can I answer, sir?
Yeah.
So for the first question, I think I should give credit to the pathology department. They give a very wonderful report. Like, if, as I said, if they say it is 5 or 6, it is 100% malignant. So we heavily depend on our pathology department.
Anjana, just one. If it is category 3 or 4, as per the original Bethesda, category 3 is 5 to 15% malignant, and category 4 is 15 to 30% malignant. We have checked our data multiple times. If it is category 3, our reporting is 55.8% are malignant, and category 4, 71.4% are malignant. So
we are under staging, you are saying?
Not really, sir. When we take both benign and, what the total number of FNA reports they have made, and when we correlate with the final histopathology, the category 3 reporting here is more accurate, definitely more accurate than what is reported in the Bethesda. In US, they are thinking of molecular testing on category 3, 4, 5 because of the large number of benign nodules which are getting operated. But here the relevance would come down because our reporting accuracy is much more, there is no doubt.
Second question.
Second question, we don't encounter so much of what you call toxic.
Is there? No. How many in the end it turns out to be benign? Have you had any cases like that? I mean, you have an FNA which is
benign. This is the data, sir. Whatever I have told now, 55.8% malignant, 44.2% benign. Category 4, 71.4% malignant, 28.2% for 6% benign, that way.
I think
the final histology.
Yes, final history.
two more comments that I would like to make. We have quoted only one study which said that 100% of the relapses are occurring in the first 8 years. Alright, that's what we quoted. There are hundreds of papers where you can see that 20% being given happening in the 20 years. 20 years. Okay, 20%, that's very easy to remember because 20% is happening in 20 years. So I think 8 years, fully agree that the first maximum happens in the first 1 year or in the first 8 years, but they do have, recurrence is happening, long-term recurrence happening, not to the local site, metastatic site. Okay.
One difference with this paper compared to the other papers is that other papers are more of the older data. This is the newer data from 1990 on. The surgical protocol has changed.
Agree, fully agree. You agree, fully agree. That's not the reason I agree. But the natural history of disease has not changed. So only the management you have become better. You become better in your management. That's the only thing you can. I think one more last question I would like to ask is, why are you so scared about radioactivity? Why are you so much scared about radioactivity?
So two papers have come. One is in 2011 from the US. It's a SEER database, 35 years follow-up. The incidence of malignancy, like they've analyzed 14,800 patients. The incidence of second primary malignancies was 3,435 or something. And then this year, in JCU, another paper has come, 42 years follow-up, more number of patients, and this incidence of second primary malignancies across all sites is increasing.
Agreed.
So, and this is seen more after 20 years. Most of our patients are young patients.
Agreed. Again, the problem is because of the amount of radioactive iodine being used. So your data which are going to project will be something which are used, just like the initial one you quoted, 20 years back, but I think nuclear medicine people here, no? Anyone?
I have faced that.
Okay, that's fine. I think because 100 versus 600 versus 1000, I think you are molecular wise, then I have to give grade and see. Now what I'm telling you is, would you like to go for a radioactive iodine study in all these patients?
Not all patients.
No, I will ask is all. Would you like to say that the low risk or the low risk I would like to go without going for an iodine scan? Why I'm saying is because you said your surgery has to be really good.
Yeah.
Okay, for you too. And you say that 15% of the 50% your recurrences which occurred has been quoted as persistent disease, more than 50%.
Yes.
Not a recurrence which is happening. Okay.
Nearly all, to be frank, in our.
No. So, if you can pick up your with an iodine scan, which you think may not be a problem in the long run, do you think that is it not better to go for an iodine scan and then take a decision much more than leaving it at that level?
See, this was what we were following initially. So, before coming here, I've practiced in places where all patients are undergoing radioiodine scan and therapy. But after coming here, when radioiodine scans were coming negative, we have evaluated our data, and we have also looked at data from All India Institute of Medical Sciences Nuclear Medicine Department by Dr. Bal. And then that's how we have been following up. So we are serially looking at thyroglobulin, anti-thyroglobulin values. So low risk patients, we are following up with TG, anti-TG. And when the patient is following the excellent response, then only we are following up. Because in the excellent response group, as per the ATA data, only 4% patients would recur later on. And in our group, none of the patients who have come in, the ER has changed into any other, like BIR or SIR, none of the patients have moved. Intermediate and high risk groups, we are doing a radioiodine scan. If the radioiodine scan is showing an uptake and thyroglobulin is elevated, they will go for radioiodine therapy because we are also worried. But by following up this protocol, if the radioiodine scan is negative, even if it is intermediate risk or high risk patient, we would just follow up the patient. And by doing this, from 100% of radioiodine therapy which is happening in 2014, now it has come down to 12.5%. So, with such a rising incidence of thyroid cancer, this protocol really helps.
So I think the question is more regarding one thyroid scan, isn't it? It's not about therapy. So 20% had minimal disease minimal thyroid tissue after the scan, on the digital scan in your initial pilot observations before you gave up a routine scan as an option. So that means 80% did have some thyroid tissue there. That's what one understands. So if it's low risk, that's fine. So therefore the risk of developing a malignancy is low. But still a scan would be, just a baseline scan after surgery may be a good idea, perhaps. That's the question.
So one of the things behind it is, suppose it is a low-risk cancer by means of a biopsy, and you do a radioactive iodine scan, and you say there is a minimal uptake. That's what happens with Shawn's cases, because I see all of them. So what happens is that even if he does a thyroidectomy, and most of the time I get no uptake, right? And some of this time you may get a minimal uptake. So even if it is a minimal uptake, my decision to give radioactive iodine doesn't change in a low-risk case. I won't give radioactive iodine.
Yeah, so but it's still documented.
Yeah.
So this is as you get a large cohort, you will then discover. You will discover that there is a problem.
So that being said, first question as to what's happening. I mean, you're right. You would have seen this more for 30 years or 40 years, but even for the last 15 years or so, when I started doing my MD, at that time, our protocol was any patient who has got a thyroidectomy. In fact, our trust from surgeons was so low. Rather than doing a radioactive iodine at the end of 3 months, we used to do it at 1 month. And if the uptake was more than 10%, we used to send them for a revision surgery. Now, after start practicing, when my surgeries started being done by a oncosurgeon, then we started getting, multiple people are doing surgery, so we started getting cases where there is no uptake. So initially I was quite surprised, and I asked the neurosurgeon, this is a patient with a thyroidectomy done, and there is no uptake. So then he gave me a list. Now, if you get surgeries, maybe it's a little controversial, but let me say, if you get these surgeries done by X, Y, Z and surgeons, you will get no uptake. And if you get these surgeries done by so-and-so surgeons, there will be some uptake. So that's probably because people are moving more towards a central lymph node dissection as well as the total thyroidectomy. That could be the reason. So I really do feel the long-term data that you are speaking about, in the next 10 to 15 years, probably the early recurrence data and the recurrence data has totally changed. So this paper probably will be an initial indication for that. Now, one question to Shawn. I think the last slide you said about lateral lymph node sampling. Okay, I think we discussed this once, but that is something which you have started recently only, right? I mean, how are you finding that? Because I am still not very convinced.
See, we started doing a frozen section for lateral nodes, even if the ultrasound is not suspicious. After seeing some of the, when we operate some patients for CA tongue and do a neck dissection, some of the nodes are showing papillary thyroid carcinoma. So that's how we thought why this is happening. So we started frozen section sampling, and we found that some of the nodes are coming positive even if an ultrasound is not showing any uptake. And one more thing, after analyzing our initial data, we found that the intermediate risk and the low risk, we usually expect low risk to have a better results than the intermediate risk. In our low risk data, initial data, 88% of patients were an excellent response on follow-up. But intermediate risk, 96.75% patients were an excellent response. Because intermediate, we were doing a neck dissection in intermediate risk. So that's why we started sampling. And in the last 2 months itself, we have 4 patients who have shown lateral nodes positive, which are not suspicious on ultrasound. And Ramesh sir, just one point, why you are asking what is harm in doing a radioiodine scan in low risk?
Just the one baseline scan. I'm not asking you to update.
No, but what is the scan? See, the patient, if it is not required, patient has to prepare for 1 month. They have to be on iodine-free diet. They have to be off thyroxine. Or if they are going for a recombinant ESH, it's again going to costing 1 lakh. What is the need? It is not required. That's why we can follow up safely with TG.
It's not set in stone yet. That's the only one.
Dr. Anjana, excellent presentation and data analysis. What you have told very clear. So before, maybe as a junior consultant, when we analyzed our data, it was only 7%. You rightly said it is now almost like our thyroid malignancy has gone to 40%. I think all of us should be aware of that. It's in the 25 years of my surgical practice, I've seen from 7% to 40% of malignancies from those cases which are getting thyroid surgeries done. Regarding radioactive iodine, our policy in the department is whenever it's micropapillary single focus, we don't send them for radioactive radioiodine investigation. But if it is multifocal or if it is more than 2 centimeter lesions in the biopsy, we send them for radioiodine investigation. If they say there is a remnant, then invariably we subject them for ablation as well. Thank you.
This can go for hours because I think more and more people get in now, but everybody is feeling hungry. I think anyway, good presentation anyway, Dr. Anjana. I think. Thank you. So go to the next topic.
Respected Chair, senior colleagues, my dear friends. We'll start with this presentation. I'm just going through a few cases which you the way we have managed for the last 8 years, some of the very interesting cases. And this is not limited to the head and neck surgical oncology department, because this work is essentially a work of the whole Lakeshore, which you will understand. When I joined way back in 2014, for the first 3 or 4 days, I was sitting in the OP without seeing any patient, which was completely new to me. And after that, the first major case actually was referred by Dr. Gangadharan. He sent this patient, who is a 60-year-old male with a carcinoma of the mandible. This patient was to undergo a segmental mandibulectomy, selective neck dissection, and he required a free bone flap reconstruction. So this is not a case which you want to do this was what was advised by my seniors. You should start with an easy case first. For the first 10 cases, it should be safe. If you're going for a free flap, it should be a safe radial artery forearm flap or something. Then only you start with the bone flap. But when you're getting a patient, you have to, and yeah, you're trained enough to do it. So I went ahead with this case. But at times, we may be confident, but we may not assess the situation properly. So this surgery, the issue was I was not having a team at that time. We didn't have a full-time plastic surgeon, a microvascular surgeon. So we went ahead with, we cannot say like the surgery, there was nobody else to really help. I called Dr. Jacob Chacko, who was working in Lisi at that time. He just visited just for the plate contouring. And then I went ahead with the segmental mandibulectomy neck dissection and this free bone flap reconstruction, which lasted for around 15 hours. And then I found, just before doing the microvascular anastomosis, I just found that the microscope was not having a viewer spot, like the assistant spot, and the nursing staff was not really trained to assist. And you were really, like, you had to manage the situation, that's all. And we came out of it. The surgery got over by 2 a.m. in the morning, when I started at 10 a.m. in the morning. And at that time I knew that if some re-exploration had to be done, you really don't have the energy to do it again. Fortunately, everything went together, but that was a learning lesson. Because as a one-man army is not very strong. You can always call it a one-man army, but it's not really an army. So you have to involve a team for that. And when I approached all departments to start a multidisciplinary tumor board, the response was excellent. We usually think of this as not an academic institution as such, but the interest in academics with each of these departments, the way they have responded was wonderful. I have not seen in any other tumor board so many radiologists coming for the tumor board, so many pathologists coming for the tumor board. Dr. Gangadharan, there was blessing from the Dr. Gangadharan and Dr. Pushpa. And Philip was the radiation oncologist at that time. We didn't have a radiation department. Philip was working with Dr. Gangadharan. So Philip was coming for the tumor board. Our endocrinologist at that time was Ramesh Gomez. Ramesh would come for the tumor board. So it's like the Sri Padmanabha Swami Kshetra cellar, because there's a treasure inside and we are hiding everything inside. That's what I felt. There's so much treasure in this institution which is not utilized, because we are not like, probably that's a whole story with Kerala. So just coming back to the case, so surgically we needed to incorporate more people. So this was the way a mandible reconstruction would appear some time back. even now in many of the institutions, without facilities, this is how mandible reconstruction would happen. And the present concept of mandibular reconstruction was to get a 3D planning done and a for bone flap reconstruction. So if you need some help, actually, if full-time consultant is also, it's not available, you can take help from outside. That's what I learned. So Dr. Sherry Peter, who is working in Asta, who I knew before, he helped me with the 3D planning. I would call Jacob Chaco also in between. Then Jose Tharail sir agreed to come for every case, so that was really helpful. And these are the resections. I think these resections only a surgical oncologist would call it an aesthetic resection. For most of the people, it would appear more gruesome if they are kind enough not to call it butchery. So, as we went ahead with more cases, we found some issues with the lip split incision and all. So we decided to somehow avoid this facial incision at all and then go ahead with a mandibular reconstruction. And over a period of time, we found that any mandible resection can be done without a facial incision. So in the last 6 years, all these oral cavity resections, we have not used a facial incision. So, it's generally said, like head and neck cancer patients in Tata Memorial Hospital where I was working before, the general talk is that, see, none of our patients, head and neck cancer patients, they can act in movies, they cannot sing. But actually it can be reconstructed. At present situation, we can reconstruct it to a very aesthetic level. And not just aesthetic, functional level also. So this patient has undergone a segmental mandibulectomy. He has undergone a free fibula flap reconstruction. This is 8 years post-op. I think he was eating this apple immediately after Argentina won the World Cup. So that extra energy was there. Then we started doing more soft tissue reconstructions for the tongue cancers and all. We tried different types of free soft tissue flaps in this time. And we also learned that it's not just about harvesting the flap, the way you place it, the way it is inset, that is what is giving the functional results. And then these are all because of the patients coming and asking you for small issues they have, and we are trying to address it. Like anterior third tongue defect, there is no reconstruction. It was not, usually there is no reconstruction at all. But when a doctor is coming and asking, she is a practicing doctor, she needs some reconstruction, then we need to really think about what can be done about it. And we came out with this small flap, which gives an aesthetic appeal to the tongue. And this is a new reconstruction for the tip of tongue. And as I told, people think that tongue cancer, you won't be able to sing again. So, he's undergone a surgery for tongue, marginal mandibulectomy, and then reconstructed with the fusicutaneous straight flap.
Probably couldn't sing as well before.
So it's not just important to do surgery, but I felt it's important to give the patients the confidence to go out and give them feel that they can really perform like before. And to be frank, all these patients send the videos back to you just to ensure, I think just to make you happy, they are sending the patients back to you, the videos back to you, so that to ensure that you can do. And when they really cannot sing, like this patient who has undergone a total glossectomy, they show their talent in other ways. They give you pictures, they are artists. And meanwhile, we got really good support from different places. When we did a CME, Dr. Anil De Cruz, who was president of the UICC, he came for this thyroid cancer, and we got good support from all over Cochin and Kerala. We did airway training programs, which we conducted for the nurses mainly, because we found that the tracheostomy management is an issue, and some of the patients had issues in the post-operative period. And then we realized that microvascular surgery is giving good results for a lot of patients, but for some patients it cannot be the answer, because there are certain patients who cannot really undergo long procedures due to the comorbid conditions. There are patients who are undergone post-radiotherapy setting, and with the recurrence, the surgery is highly risky. And then again there is an issue, like anything less than a microvascular surgery was considered a bit inferior. That's the general perception which is going on. And many institutions who cannot do it, like some of the government institutions who do not get so much anesthesia support, they wouldn't be able to give a proper reconstruction. And I felt, to be frank, this was a bit unfair, throwing this perception on them, because there are other options also which may give results. So, and definitely there are financial issues also. So we came up with this new reconstruction called ilented facial artery myomucosal flap, which is based on the tissue from the inner side of the cheek. This was the first publication from India for that. And we started reconstructing tongue in selected patients with this flap as well. One issue with the fasciocutaneous free flap was that the floor of mouth area, you don't really get the movement with the movement of the tongue after you do a fasciocutaneous free flap. So this particular flap gave a good movement for a floor of mouth reconstruction as well. We also, for a small mandible defect and all, we started doing a local facial artery based bone flap, which was also described for the first time. And we did comparison studies between patients between ilented facial artery myomucosal flap and fasciocutaneous free flaps, and we found that it had similar speech and swallowing outcomes. There was a reduction in the post-operative operative period and the ICU stay, and there was a reduction in the cost as well. And from Lakeshore, we published this paper, which is in the British Journal of Plastic Surgery, and this is the largest series till date in facial artery-based myomucosal and bone flaps in head and neck reconstruction. Now for larynx, I'll just tell about two cases. This patient, both these patients, they are 49-year-old patients, and both were not having any comorbidities. And this particular patient came with a recurrent subglottic carcinoma, a small lesion in the subglottic area. Usually these patients require a total laryngectomy. But when we saw both the vocal cords moving well, and the patient was he was the only working person in the home, in his house, and so we just thought whether we can do something different for him. So we tried this procedure, which is actually for a Gilbert procedure, which is actually described for a thyroid cartilage or the glottic carcinoma. And this was done using a endoscope guided resection planning. customized for this patient, and using tissue taken from the temporoparietal fascia flap, free flap with the conical cartilage and buccal mucosa graft was used for this. I'm not going into the more details of this particular case, but this actually helped preserve the voice function of the patient.
While that's being fixed, I just want to just say a word that it's really nice to see people documenting their data. I think we have accumulated the last 2 decades such a lot of data, and when it's well documented, so many lessons are learned. In fact, I propose that our web should be a private domain where we can actually post our data. We don't have to tell the whole world about it, but at least we should share it among ourselves, and that's something that I think we should do immediately, which will really make us understand how good our own colleagues are, not only in terms of what they deliver, but the fact that they audit their results and innovate, and in a most ingenious manner.
And the second case, again, this was again a special case, a 49-year-old male without any other comorbidities, presenting with the carcinoma of the pyriform fossa. It's the only procedure which has been described. All of these patients usually undergo a total laryngectomy. Only procedure which has been described for this is a tracheal autotransplantation, which actually which has certain issues, like which is a 2-staged complex procedure with a lot of issues. So this patient was ideal for tracheal autotransplantation, but it's 2-stage, the financial issues, many things were there. So for this patient again, we went for a new procedure, which is called tracheal advancement with myomucosal island flap. It's just that all these patients usually undergo a total laryngectomy. So this was again a new procedure for laryngeal reconstruction. Both were published in IHNS, which was the highest impact journal in otolaryngology at that time. Just one more point about larynx. We have the first carbon dioxide laser in private sector in Kerala. That's there for the last 5-6 years. One thing which I wanted to tell us, for stage 1 and stage 2 glottic cancers, these 2 options are there, carbon dioxide laser and radiotherapy. These have been compared, multiple meta-analyses have been done, and it is almost certain that the voice outcome with both these are the same, but going for a laser has some advantages. It requires just a 1-day treatment, and the larynx preservation rate, in case the tumor occurs, is more with the laser. But still I see so many patients who just undergo a biopsy from outside general anesthesia, under general anesthesia, when it could have been finished off in the same sitting. You're taking the patient under general anesthesia for a biopsy, then the patient is coming with some dysplasia or something. Either you keep the patient on follow-up or send the patient for radiation without giving the patient an option. Yesterday also I saw a patient who has been biopsied 3 times under general anesthesia for a vocal cord lesion, coming as dysplasia, finally coming as carcinoma in situ, sending the patient for radiation. And the patient is coming after almost 1 year with a laryngeal dysfunction. This is a post-transplant patient, and the patient was never explained that there is another option at all. So this is something I wanted to share with you colleagues, which you should understand. And the results, like I've chosen the most difficult patient, all other patients are having better results. This is a post-radiation recurrent glottic carcinoma where the whole cord has been taken out, and the cord is not there, you can see, and you can see the voice. So just wanted to convey, because we are still the only hospital in the private sector in Kerala which is having this carbon dioxide laser, and thanks to the management for that. And even the cost has been compared. Cost study has been done and found that the cost of both the cost of treatment is lesser with the laser. at least like whenever we are offering a patient a treatment, at least this should be explained to the patient that there is another form of treatment also. So that's why these multidisciplinary tumor boards are important, because it becomes transparent and the different opinions can come. So there's somebody to criticize you. Then we have done a lot of endoscopic skull-based surgeries, thanks to the excellent the neurosurgery team and the radiology team we have. Because before all these surgeries, Dr. Dara and Dr. Julie can actually make you do a virtual surgery before going for the surgery itself. So I'm not going for more details of that. Then this was a anatomical landmark which we studied and published for facial nerve identification in parotid surgery. This was published after I came in Lakeshore, though the study was done before that. It was published in 2015. So we were doing cases by this method, but to be frank, in India, in many of the workshops, I never found this being discussed. So I thought maybe this is not of much interest to others. But it was very heartening to see that 2 universities in Egypt this year, they have published a study based on, they have studied this particular paper and this particular technique they have studied, and they have published a paper. They have also registered it for a clinical trial. And then again, there's a video in YouTube from a surgeon in Greece who is using this particular method. And one more thing about parotid surgery is that whatever surgical technique we follow here is a concealed incision parotidectomy. So incisions are not usually visible in parotid surgery. And for patients with a facial nerve palsy or facial nerve which we have to take, there's some technique called facial reanimation. There are different procedures in facial reanimation. So this is a facial nerve graft, where you do an immediate cable nerve graft. So, and the second patient on the right side is a gold weight. In this particular patient, it's a static reconstruction. So even with a facial palsy, you can really have a eye movement restored. This is something called a temporalis tendon transfer. So you really need to customize the procedure for the patient. So eye closure, exposure keratitis can be prevented. These are all patients with full facial palsies. Just coming to the pharyngeal reconstruction, because we have got very few refractory corrosive injuries, but they were really difficult patients because they came with the most challenging locations, that is a proximal 1/3 esophagus. This is a 26-year-old female with a history of corrosive injury which happened in Canada. She underwent a PEG tube insertion from Canada. She underwent a tracheostomy as well. Then she had complete stricture from that time, and patient had opinions taken from multiple centers, and somehow the patient came to Dr. Philip Augustine, and he referred the patient to me around 1.5 to 2 years back. This patient was advised nothing can be done for this patient because there was a stricture from the level of oropharynx, because you cannot really see the food passage or the airway, and apparently it was thought that nothing can be done. So when we did the endoscopy, this is going from the oral cavity behind the tongue, and this was the area where we are seeing the stricture. And you can see some movement over there. And by that moment, we felt that there is some hope, because that's the air pushing the strictured area. So that means the air is coming out of the larynx. So we did a reverse endoscopy from the tracheostoma upwards and found that the vocal cords are perfectly mobile. So we knew that there is a hope. And then we went ahead with we really had to plan a lot for this particular patient. And then we went ahead with this procedure, a colonic transposition with a slit bellflower insert, laryngeal suspension, and we placed a stent for 3 weeks. I got tremendous support from the gastrosurgery team for this. Actually, the video, the endoscopy video is also there. And this is a video fluoroscopy. The patient is now swallowing.
In 1904 and first produced in 1906. The silver box was the first
She was told that she would not be able to swallow, eat food or by mouth or talk for the rest of her life.
In 1904.
Then again, a 24-year-old female from Gujarat with a corrosive stricture of esophagus. She underwent her total esophagus and stomach were destroyed, and she colonic transposition was attempted from Gujarat, which got necrosed. A free jejunal flap was, like, Dr. Ramesh saw the patient in Ahmedabad and brought the patient to Lakeshore. I think it was in 2010, before I joined. A free jejunal flap was tried, it failed, and the patient was being fed through the jejunostomy tube. So, apparently there was no other option. But then Dr. Joseph and Dr. Ramesh planned a skin tube for this patient, which I think Joseph sir took out of his experience in the 1970s because such a reconstruction was never tried before. It was a rectus musculocutaneous flap, but usually using an expander. This video was sent by the patient because I joined later on. That's him using the expander. Then this is how the skin tube was made. But unfortunately the skin tube was non-functional even though it was placed close to the pyriform fossa, and the patient was again on feeding jejunostomy for 3 years. And then after I joined, we planned what else can be done. And there was a midline stricture at the post-cricoid level which led to the aspiration. Even if the feeding tube which Joseph created was intact, there was this stricture which needed correction. So this was addressed, and we went for a different type of insert for this patient. This is called an intact bell flower insert for a hypopharynx. These are all terminologies which we are using so that we don't forget how to do it later. And by the time we had been doing this particular flap for oral cancer, which could be used for this patient for her pharyngeal reconstruction. And after a lot of struggle, 8 years after her corrosive injury, now she is able to have food. Now she's a successful home baker. She makes sweets, she sells cakes, and these are the photographs she sent me after that. And these...
First of all, I want to thank all my doctors. With all their efforts today I am meeting and speaking with you after 8 years and 25 surgeries. Never lose hope. Hope is the only thing that will make you survive and gives you courage to fight back.
All credits to Dr. Ramesh for keeping this on for 8 years and allowing incorporating others to get the surgeries done, incorporating multiple opinions, and for Joseph sir for thinking out of the box and taking all the risk. Even you may invite ridicule if you try a skin flap like that and if it doesn't work.
First of all,
this is just our oral cancer data, just the results, survival results I'm telling. For stage 1, we were keeping the data updated all the time, so we knew how the patients were faring. And then we found that we were getting good results in the early group, but still we were losing some patients in the early group. But in the advanced group, yeah, we were losing more patients than the early group, but still a good number of patients were surviving. So is the current staging really seeing what is happening to these patients? So we thought more needs to be done. We in order to improve our data analysis, we actually, to help ourselves, we started conducting biostatistics course, and we got excellent support from our colleagues here. And now, to really know what is happening to these patients, we wanted to enter into a basic science research, and we have signed a research memorandum of understanding with the Tata Institute of Fundamental Research on oral cancers. This was again a conference which we did recently, and this was a very interesting thing where I got excellent support from the Lakeshore colleagues for raising fund for a patient for a surgery. This was a TV game show which we won. And this photograph on the left, patients keep sending a photograph, but this photograph on the left is especially important because this is not a patient who I have operated. This is a 9-year-old child. She was having a lesion in the carcinoma of the head and neck area only, but which required chemotherapy. She was undergoing chemotherapy. I have consulted the patient a few times, taken care of her. And after she passed away, her parents brought me this picture telling that she wanted to give me this a few days before she died. She wanted to hand over this photo to me. And see, I have mentioned a few departments, I have put a few photographs, but all these departments have contributed. Our 8 years means all these departments have really contributed to the head and neck work which we are seeing here. This is perimetric and microbiology, sorry. And the most important department, which is LP, is the anesthesia department, because head and neck cancers are the most difficult for an anesthetist when it comes to intubation. And they have never really refused a case, or maybe I feel like if they refuse a case, it cannot be done almost any other place. So thanks to the anesthesia department for that. Thanks to my own colleagues. And this is one of my patients. So she has challenge for you. Like, there's a prize for trying to get it right. Like, she'll sing a song. And if anyone in the audience can sing it, we'll be giving a prize. I think the MD will give the prize. So see a tongue surgery reconstruct. Would anybody, is there anybody who is willing to try this song? Vivek? I'm sure Mohan sir didn't attempt to sing that, but I think he can dance. Thank you so much. Thank you for the patience.
Thank you, Dr. Shawn. I think an excellent presentation. I think the takeaway message is, if you want to sing, meet Dr. Shawn. I think much more than head and neck, I think more projectiles to say that singing is done best in head and neck oncology. Thank you. I think it's a very nice presentation to hear. I think the story about you, how you came up, and how the whole hospital helped you to do good jobs. And just like lecturer was pointing, I think keeping all records and trying to collect, I think, go ahead. And thank you. I think any comments, queries from the audience?
Any comments, queries?
I think if there are no further comments, I think it is already too late. So thank you everybody for coming to this interesting session. I think we will wind up here. Yes.